Hi everyone, my name is Melanie Grant, and this is C&M Glass. Today, we're talking for sections Cardiovascular and Urinary in the CPT surgical section for class 2030, which looks at codes 33010 through 37799 and 50010 through 53899. Today we'll be doing a brief overview on the urinary system, as there's a lot more detail that we'll be focusing on when we talk about genital urinary for male and female reproductive systems. So the majority of our class today is going to be focusing on some of the very specifics with cardiovascular coding, and this is just a brief overview, so make sure you still look at all of the videos we have posted for this week, as well as the reading in your book, as it will help you tremendously. So let's get started. We have our key points today. We'll be talking about the cardiovascular system in detail for pacemakers, some tips and guidelines on when to look for HCPCS or medicine section coding, some details about bypass grafts, and some of the information about stents, balloons, balloon angioplasties, and the cardiac families. When we talk about urinary, we'll have a brief overview in blue down here of catheterization and some of the different services that you'll see with urinary specifically. So the first thing we want to talk about are pacemakers. Now, if you recall, a pacemaker is going to be inserted into the heart and may have its own sac around the heart. We'll have our little heart here. Depending on where the pacemaker is going, depends on how many leads and how many electrodes you have. So you're going to have a generator with those electrodes and leads going into the heart. Now it's important to identify this first and foremost because the different types of pacemakers will depend on how many leads, whether or not it's permanent or temporary, and whether or not you're inserting it, removing it, or replacing it. If you look in your CPT code book, and I have here in front of me the 2018 CPT Professional Edition from the AMA. You may have a different version of the code book, and that's fine, but I'm going to skip over to where cardiovascular section begins, which in my book starts at page 197, and I can notice that there's about 3 pages worth of table of contents. So it's very important when you get started that you look and find where you're at. The first section we look at is in fact going to be almost the first section is going to be on pacemakers and implantable defibrillators. Now it's important that you read through these guidelines. There's about 2.5, almost 3 pages worth here. The reason for this is because when you take tests and when you're coding in this system specifically, there will be a lot of guideline information that will direct you specifically to the code you need to clarify questions that you may have. If you don't look at these guidelines, you could be missing out. Also, on bottom of page 203 in my code book, I have a very lovely graph that's going to tell me, based off of the type of pacemaker I have and the type of leads, exactly what code or codes I should be listing. For this reason, I really recommend that you look at these because it's going to help you in that code selection. Now in here, you have the differences between insertion and removal. You'll notice that there's not a code for replacement except for removal and replacement of a defibrillator, pulse generator, and subcutaneous electrode. So when you're looking at these, in the instance where you have a pacemaker that is not an implantable defibrillator pulse generator, you will need to do the removal of the previous type of pacemaker as well as insertion of a new one when there's a replacement. Let's see, codes 33210 through 33221 are your temporary pacemakers. These are going to be put in transvenously. They're not intended to be permanent, so a lot of times a patient may get this done during an incident with the plan to come back and get a more permanent one. And so when you have one of these, you have the difference between insertion or replacement, insertion by itself, and then when you go into place a permanent, you have the difference of upgraded. And so you'll see at 33214, upgrade of an implanted pacemaker, conversion of single chamber to dual, including removal of previously placed pulse generator. So you want to pay attention to those details to make sure that you're not using insertion and removal codes if there's an upgrade or replacement code, but be aware of when there are not replacement codes because you'll need to use those. So really the best thing I can tell you when you're going through these is to take your time, not to let it throw you off, and make sure you read through the coding options. Okay, our next thing that I wanted to talk to you also about are your HCPCS codes for some of your devices. So one of the things with many of your payers, especially Medicare, is that you will get denials on cardiovascular procedures if you don't have the device code along with it. Some of these are accepted by insurance and some of them not. If it's a Medicare patient, they do use the HCPCS code book, and so when you see that, you want to make sure that you're using it. Now I have listed here some of the codes that you'll see for cardiac pacemakers. For the most part, you're going to be looking at is going to be the leads when you're putting them in. So you'll be seeing those, as the device itself won't necessarily be separately reported. Just make sure you're always aware of when to add those by looking at your C-section to see if there's anything that matches the codes that you have. For the most part, your pacemaker and defibrillator codes, though, will be by themselves, and it will indicate to you if it includes the for the procedure itself. So a lot of times if you see the option for a HCPCS code or if it mentions Medicare patient, make sure you verify, should I be using a HCPCS code along with this code here for the pacemaker? Okay. The next topic we want to talk about are CABGs, or coronary artery bypass grafts. And we'll find these starting on section for 33510. The first thing to keep in mind when you have a CABG is that you're going to have multiple codes, either for if it's a CV, meaning, or an AV, meaning it's an arteriovenous graft. So you're using what's already there in order to support different location for the artery or vein that you're bypassing. Or if you're harvesting and you're harvesting from another vein within the body, such as in the leg, which is commonly done, there's separate codes for those, and you will need to code those separate. In the instance where you're doing a combined AV graft, they do have codes for the AV graft as well as additional codes that need to be reported. And those codes are going to be either the Sylvanus vein graft is included in the description, should not be reported separately, but the procurement of the artery should not be reported separately. The ones that you do report separately on these are going to be if you're doing the arteriovenous graft, that one was reported by itself, and then the arterial graft is reported separately. So if you're getting the saphenous vein graft, you want to remember that that is included. If you're getting an artery for grafting, it is included. So the only time you have those two separate are going to be if the harvesting is done in a separate session for a different area. Pay attention to these guidelines because they're going to give you that detail and they're going to give you those code sections. In the instance where you have a graft that does not include guidelines, you want to code based off of the specific detail within the code itself. Okay, so the other one we want to talk about is catheters. When you're placing a catheter, there's a lot of different types of catheters you may see. In our textbook, we have the catheters and vascular families are listed in Appendix L, which is in your code book, but you also have them reported on pages 756 and 757. The reason this is important is because when you have a catheter that's placed, you need to identify where the vascular family is coming from in order to say where it's placed to or from. So you want to look at those codes, and these ones are going to be found. Give me just a moment, I'll pull that up for you. So for some of your catheters, you have implantable venous access ports, which start on page 252 of my code book and start with codes 36570. These are where some of our catheters are. You do have in this version of the textbook, you have a table, which is really great in this version of the code book, sorry. And most of them should have things like this to help assist you. But you also have a table in Appendix L, which is going to give you those catheter families. Now for this one, this is for central venous access procedures. And so it has the different types of catheters based off of guidelines on whether or not it's tunneled or non-tunneled, meaning that they tunneled into the vein itself, where it's tunneled to. So you have some options of with and without port or pump. So these are things that you would be looking at in the documentation. Whether or not it's a catheter that's meant to be permanent or semi-permanent or temporary. You have codes for insertions, removals, partial replacements if there's issues with part of it and they didn't replace the whole thing, just the catheter, versus a complete replacement. And then you have any kind of issues like getting clogs and stuff within the catheters themselves. You'll want to remember that catheters are going to be used for a multitude of issues, just getting blood or providing various medication directly into the bloodstream. And so it's important to identify what the purpose is. If it's for hemodialysis, you have a few procedures that are separate. And so when you have the catheter placement, you want to look at the codes and make sure that there's no guidelines saying this includes a catheter. So in the instance where you're coding the catheter, make sure it's not part of the original procedure. Now your dialysis procedures, you do have quite a few guidelines on them as well. Differences between peripheral dialysis, central dialysis, peri-anastomotic regions, and through dialysis circuits. So you want to pay attention to what type of dialysis you're doing and take a look at those definitions to see if there's any specific guidelines when you're coding for these. Other than that, paying attention just basically to where you're at and what type of procedure is going to be the most important thing I can give you with the cardiovascular system. Pay attention to guidelines that say see this or code also, because those will really give you the additional details that you need. Now, in your catheters, you do have C codes for when you have a device that a catheter is being left behind. And so again, just like with your C codes for your pacemakers, if it's a Medicare patient, pay attention to see if a device code needs to be applied as well. So that's our brief overview of cardiac. I really want you guys to take some time to look at some of the videos that we have posted this week, as I think those are going to help you tremendously in identifying when to code multiple procedures. The most confusing part of cardiac coding is how many codes you need to use for specific procedures. So that's one thing you want to make sure you pay attention to in your readings this week and reviewing your guidelines. Now the last part I wanted to talk to you is just a brief overview on urinary system. Again, talking about catheterizations, different type this time. So instead of going into a vein, going into the urinary system. And so we have our patient here with some kidneys. I just want to kind of show a little diagram here. We have our bladder and urethra, okay? And so just kind of to get started, when we have a catheterization, it is going to be typically endoscopic, although you may have procedures that will be endoscopic and then percutaneous, meaning that they go in through the urethra and there's a block perhaps, and so they had to penetrate to go out and back in. Or if they're going in through the urethra to get to another part of the body, such as the prostate when we talk about male reproductive systems. Now, one of the things to keep in mind is a lot of times you're going to see procedures where one thing is done on the left and one thing is done on the right, and it's all done in the same setting. Keep in mind that your approach is going to identify whether or not there is a lateral option for procedures in the urinary system. So if I have a cystourethroskop that's being put in through the urethra and through the bladder, and then something is done separately to each of the kidneys, I cannot claim laterality for that. And so there should not be modifiers for bilateral or left and right procedures. And that reason being is there's only one urethra and only one bladder. And so even though there's two ureters here, even though I've made them one, even though there's two ureters here, and different procedures can be done, you only have one urethra, and so therefore that procedure cannot be bilateral. A lot of providers get confused about that, and a lot of coders do as well. Now also keep in mind, when you're doing procedures, if you have a cystourethroskop and you're just going in and looking, that is going to be considered a diagnostic procedure. However, if while you're looking you found something and the provider decides to do a biopsy or to clear a blockage or some other type of procedure that's necessary, at that point, we no longer code the diagnostic procedure. We convert our procedure up to a therapeutic. And so the therapeutic procedure will always include that original cystourethroskopy, even if it's done on the same day but in two separate settings. You can still, however, report certain codes that are done on the same day in separate settings. You may need to use modifiers, either 51 for multiple procedures. If, for example, they go in and they're doing a procedure on the left and then a separate procedure on the right, and the cystourethroskopy does not have the option for all of the procedure that was done, you'll report both. So an example of that, let me get into the urinary system with you. Okay. So if you're in a cystoscopy, urethroskopy, or endoscopy, and you have here for code cystourethroskopy is 52000. If I have 52005, which includes the cystourethroskopy with ureteral catheterization and with or without irrigation, insulation, and or uretopyelography, exclusive of radiological service. Let's say that that was done, but then at the same time, a biopsy was also taken, which is 52204. I would then have modifier 51, which I can append to these codes. I would append it to the secondary code, which would be the biopsy here. And it would identify that there were multiple procedures done. In the instance where the provider goes in and does the cystourethroskopy, as mentioned, with ureteral catheterization, and then with or without irrigation, insulation, so on and so forth, and then came out and then later went back in for some reason, perhaps there was something on a radiology exam that they wanted to go back and relook at, and at that point they did a biopsy, then I would add 59 to say that these were done separately. Or I might look for an X modifier, depending on the type of reason that it was a separate procedure, looking at the HCPCS to see which one would be most appropriate. So those are some of your codes with the urology system. We do have other procedures we'll be talking about when we talk about the male and female reproductive systems, more with the male systems. But it's important to identify these particular procedures. The last one is transurethral surgeries. These are going to be very similar in identifying different codes depending on what is included and what's not. The one thing that you do want to keep in mind is that if a catheterization is done during a transurethral surgery where they needed to have that open or opening the urethra to drain, that would not be coded separately. That would be coded with the actual surgery itself. And so that's your last piece on urology. Make sure that, or with the urinary system, make sure that you read through all the guidelines that are presented here. This week is going to be a little smaller on the urinary sections, and we will be talking again in detail when we talk about the male reproductive and looking at some of those additional differences. That's all we have for today. So if you have any questions, feel free to send me an email at mgrant13@cnm.edu. Keep in mind that emails do take approximately 24 to 48 hours response time from the day that it's received. So if you send something at midnight, I'm going to consider it received the next day. And that does not include weekends or holidays. So if you send something on Friday, it could be as late as Monday or Tuesday before I get a chance to respond. I try to keep up on those emails on a regular basis for my students that have questions on assignments that may be due. But if you have something that's of urgent nature, always feel free to text me on my cell phone and let me know what your questions are. Until next time, have a great day.